make sure that I'm doing it right. They have been critical to my growth and development. So today I'm going to be telling you about a program that we use to diagnose hearing loss in infants across the state of South Dakota. So first off are my disclosures. Financial disclosures, I get a salary from the University of South Dakota, and then I get financial support from the South Dakota Early Hearing Detection and Intervention Program. It is a HRSA grant. And non-financial disclosures, I don't have any, but I do want to say that my views that are expressed here are not those that are representative of the University of South Dakota, South Dakota Board of Regents, or South Dakota Department of Health. They are my own. So here's an outline of what we're going to be talking about today. First is I'll tell you about what early hearing detection and intervention is. This is important later on for how I kind of promote our program, our teleaudiology program. So call to action, I'll tell you what EHDI is and how EHDI looks in South Dakota and why we need and started teleaudiology services here. So why we need it, how we established our sites, how it works now, things that I think we've done well and room for improvement, and then finally future directions. So hearing loss is the most common birth anomaly. Hearing loss occurs in about 2 out of 3 live births, 2 out of 3 every 1,000 live births in the United States. So that approximates to about 12,000 per year. Another thing that is very important is that after birth, about 4,000 to 6,000 infants will acquire hearing loss before they get to school age. And what that means is that they would have passed their newborn hearing screening, but developed it sometime before they start school. The thing that I think is the biggest selling point for why it's important to track hearing loss is that there are a number of disabilities or diseases that we test for at our newborn hearing screenings, and you can see those on the left. So cleft palate, Down syndrome, limb deficiencies, all things that are part of newborn screening, but hearing loss is far more common than any of those other ones that are part of that panel. And in fact, I think it's compared to those first couple, it's more hearing loss is more common than all of those others combined. So critical that it be part of that newborn screening protocol. When we look at the United States, again, about 3 out of every 1,000 babies will have hearing loss when they are born, but about 5% will have hearing loss by the time they get to school age. So what that means for us, again, we're a very small state, but 33 to 44 infants each year will be identified with hearing loss at birth, but by the time, again, that they get to school age, it'll be about 5,500. Why is it important to screen for hearing? It's critical, of course, for spoken language, reading, and auditory learning. Most of our language growth happens before 4 years of age. That's kind of a critical language learning years. And so the earlier you can get intervention, the better your outcomes will be. What happens if we don't treat it? There are a lot of negatives. So one is negative effects on social, cognitive, and psychosocial development. Kids will become isolated and withdraw from their peers. They'll struggle in school. One statistic that always sticks out in my mind is that kids, even with a unilateral hearing loss, meaning that they have normal hearing in one ear and they've got a hearing loss in the other ear, function like somebody that has bilateral sensorineural hearing loss. So even if you have just one normal ear, it's not enough. These kids with untreated hearing loss will often repeat a grade or two, decrease test scores, and it'll look like these kids have behavioral problems, disruptive behaviors, but really what it turns out is they can't hear, they can't understand, and they get frustrated. But the good news is that if we treat kids early, particularly if we identify a child with hearing loss and we get them intervention before 6 months of age, they will often exceed their peers by the time that they get to school in terms of speech, language, and academic outcomes, because they get these targeted interventions prior to getting to school. So that's the great news if we can achieve that. So early hearing detection and intervention programs, it's a public health initiative that has 2 main goals. The first one is to identify kids with hearing loss as early as possible, and then get them intervention as early as possible as well, and make sure that they're connected to all the right people. So couple key components to any EHDI program. One is a new universal newborn hearing screening program. What this means is that before a child leaves the hospital, or say they're with a midwife, before they leave that center of care, they get a hearing screening. We'll go through kind of the protocol of like what that looks like, but we want kids to be screened before they leave the hospital. Second is if they don't pass their hearing screenings, then that they are followed up with a pediatric audiologist who will do frequency specific testing to see what's going on with that ear, type and degree of hearing loss, and then get them the intervention that they need. So make sure that they decide on a mode of communication. So do they want to learn orally or do they want, hearing aids, cochlear implants, whatever's appropriate, or do they want to pursue sign as their language intervention? And in addition to getting those interventions, connecting them with services like peer network groups and birth to 3 services so that they can start getting language intervention, things like that. But then also EHDI, we want to track at this level of the state and then across the nation how well we do at meeting certain goals. And those goals are right here. So 136 is what we think of. First is we want to screen kids no later than 1 month of age. We want to diagnose a child if they have hearing loss no later than 3 months of age, and then provide them with intervention services by 6 months of age. But we know earlier is better. So some programs are actually pushing the envelope a little bit, and they're looking for screening by 1 month, diagnosis by 2 months, and early intervention by 3 months. Here's a quick overview of how EHDI works. So kind of a lot on the screen here, but the first part is just screening. So getting the kids, testing their hearing. So we do a screening in the hospital. If they pass, great. If there are risk factors, we encourage a diagnosis, a diagnostic evaluation just to make sure that that kid doesn't have hearing loss. If they don't pass, we rescreen later on during their time at the hospital stay, but no later than 1 to 2 weeks later. If they pass, great, monitor them. If they don't, that's when we jump in and what I'll be telling you about today. So if they don't pass 2 times on the screening, they need to see a pediatric audiologist for a diagnosis. Once they see the pediatric audiologist, if they have normal hearing, great, we continue to monitor them. If they have hearing loss, there are a lot of genetic conditions that are associated with more than just hearing loss. And so in addition to starting intervention for language and speech and things like that, we often make referrals to an ear, nose, and throat doctor to figure out what's the cause of hearing loss, a geneticist to see if there is a genetic component to it, ophthalmology, and a couple other places too. And then, so that would be the 3-month goal, is we want to diagnose them by 3 months. And then at 6 months or earlier, we want to begin intervention. So here's some national data from 2022, our most recent data, showing that we do a pretty good job at screening kids by 1 month across the nation. So 95.6% of babies are screened by 1 month. That number significantly drops when we get to diagnosis by 3 months of age. Definitely varies by state and will be one of those states that you'll see in a couple of slides that we struggle here. And we'll talk about some of the reasons why we struggle in South Dakota. But fortunately, it looks like that number improves slightly when we talk about intervention. So of those babies that are diagnosed with hearing loss, 40% get intervention by 6 months. So what about South Dakota? In 2022, we had 12,000 live births. Great screening rate that was on par with the national average, 93.9%. But you can see that we take a pretty deep nosedive when it gets to diagnosis, about 10.9%. And of those babies that were diagnosed, intervention by 6 months is 3.7%. But that number may be low. One of our barriers that I'll talk about later too is we don't until recently, we haven't had a great way of communicating with birth to 3 and other services that we refer to make sure that kids get intervention. So state tracking has been an issue. So what are some of those barriers? These first two kind of go together, but there are a scarcity of services in South Dakota. We are still considered a frontier state. So we have not a lot of people, not a lot of audiologists that can see pediatric patients. And what I have here on the screen is a map of the different locations where we have pediatric audiologists. So we've got a good representation, I guess, in the lower right of the state, on the western side of the state, but you can see particularly centrally and northern, it's pretty tough to, we don't have a lot of access to services there. Again, what that means is that people will have to travel quite a bit, sometimes up to 2, 3, 4 hours just to get to a pediatric audiologist. And our public transportation is not great, particularly in the center of the state. Another thing that has been difficult, kind of like I mentioned earlier, is that sometimes tracking those numbers past diagnosis is pretty challenging because we have several different health systems. We have Indian Health Services, we have private hospitals, and it's tough to get all that information together. Midwives is another big one too. And then one of the bigger issues, but fortunately, hopefully we have started to address this issue, is that there wasn't a state mandate to have newborn hearing screening part of our mandatory newborn screening panel. But I think thanks to some of the things that we've provided through EHDI, the EHDI Collaborative, we've been able to show the state that it's important and that we can make screening happen. So it was added to the newborn screening panel in 2024. Just a big win. So now I'm going to tell you a little bit about our program and kind of how we got where we are today. So here's kind of how it started. At least I'll tell you how I've been able to approach it. I won't go all the way back, but roughly 2017, I believe, is when we opened our first teleaudiology site. But I'll tell you kind of how I've established one new site and then how we hope to establish a second site. So one thing that we have access to through our partnership with the state and as the Early Hearing Detection and Intervention Program is state level data. So with that state level data, we're able to look and see where our loss to follow-up is greatest. And so what we've done with that data then, particularly in the past, has said, all right, where are those areas in the state where we've had the greatest loss to follow-up? And can we establish a teleaudiology site there so that we can make it easier for patients to get to? So what we'll do is we'll contact clinics that we know are in that area, not necessarily ones that have an audiologist, but ones that are close by. And then what we'll do, or what I've done, is gone to those hospitals that have expressed interest and given a very quick talk on why, screening for hearing is important, and how the EHDI program works. And then I try to pitch the program to them, the teleaudiology program. What that means, again, is talk about EHDI, why it's important, and then describe our hub and spoke site model. And then I try to spend a little bit of time at the end emphasizing why they should partner with us. And some of those big selling points are that as through the EHDI program, we provide the equipment, we service the equipment, we train personnel on how to use it. And then I tell them that the time commitment on their end is quite low. So a lot of the burden is on us, which I think helps. And then if I have a little bit of time at the end, I talk logistically about how it works, but I'll be telling you guys about how our program works here today. So once we get buy-in, one of the first things that we'll do is purchase equipment. And luckily, there's not much equipment that we need to work with. So first one is a video otoscope so that we can take a look in the baby's ears before we do the exam. A tympanometer is used to see how well the middle ear is functioning and will give us an idea of the results that we might see on the test. These are both two very quick procedures. But then the way that we diagnose hearing loss and see the type and degree of hearing loss is by doing auditory brainstem response testing. So we'll get this machine here that also has another very quick screener that we can do if we're struggling to do the ABR. And then the last thing that we'll give the sites are educational materials. So if a baby passes, here are all the resources, here are the developmental milestones that the baby should reach auditorily, speech and language. If you have concerns, reach out to us. If the child doesn't pass, again, here's a list of where the pediatric audiologists are in the state, the referrals that we would like to make, things like that. So after purchasing the equipment, we'll identify and train support staff at the site that we're going to be hosting at. That'll be our spoke site. So part of that training includes how to use the equipment and WebEx, which is how I, get into their computer and can see the patient and can run the equipment virtually. We run through the protocol. We go over how referrals and screening and scheduling go, and then what to do after a child receives a diagnosis. This can roughly take maybe like an hour or 2 hours once I get there. So it's can be pretty quick. In terms of referrals and scheduling, so this is again maybe for your information, but so once we've established the site, they have the equipment, we're ready to go. What happens is the primary care physician, typically in that hospital system, will send a referral to the clinic that I am affiliated with, the University of South Dakota Speech Language Hearing Clinic. Note that this is separate from EHDI, but this is where I typically see patients. So once they send us a referral, the USD front desk staff will identify my availability and then the availability of the spoke site. So for ease of scheduling and predictability, I see patients every Tuesday morning from 8 to 10. And as you'll see later, we have 3 sites that are active right now. And so we'll just do kind of a first come, first serve basis. If somebody, once we get a referral, we'll just schedule them at the earliest time that we can. Then our front desk staff will contact the family for scheduling, education, completing forms, and then the front desk will also schedule the spoke site to confirm the appointment time. Some of the information that our front desk will give the patients at the beginning or the families is a consent form, things that they need to remember. So before the appointment, we like the babies to come hungry. Unfortunately, and only now can I appreciate this as a new mom. We see them early on at 8 a.m. and it's easiest to to keep the baby quiet and still during the appointment if they can hold off on feeding the baby until they get there. And then a bunch of other instructions too, but then an intake form and then an authorization to obtain and release information from their pediatrician and to be able to send that back to the pediatrician and other referrals as necessary. So hopefully you can see, at least from there, that we try to take a lot of the burden off of the site that we're working with. And this is important because I will say later on that early on in this program, we've been very lucky that the sites that we've worked with have kind of done this for free. So they've let us use their space or at least keep our equipment there for free and use the support staff's time without charging us. The EHDI grant pays for these services. So taking the burden off of them is huge. Day before the appointment, USD once again calls the family and the spoke site to confirm the appointment and once again prepare the family for the appointment. But then we get to the appointment day, and this is where the magic happens. Roughly like 10 to 15 minutes before the appointment, the staff will log on to WebEx. That's the platform that we use. And we make sure that the video is working, the remote control is working, and that we can hear each other. Then the family arrives and the staff preps the patient. So we put on the little electrode arrays or pads and make sure that the earphones are in place. Meanwhile, I'll be taking a case history while that support staff is prepping the patient. But then once we've done those things, we start into the protocol. So I look in the ears, again, using the video otoscope. So once again, what's great about these virtual platforms is that I can not only look in the patient's ears as long as I have the support staff kind of position the otoscope so that I can see in and take a look, but then we'll do tympanometry again to see if the middle ear is working, and then I remote in so that I can control the equipment. So basically the support staff is there to get everything ready. And then throughout the appointment, their main job is just to make sure that the earphones are in place because babies move quite a bit and we want to make sure that those don't slip out and I get inaccurate results. Once the testing is done, I review the results with the patients and go over next steps. And then after that, I complete my data analysis of the tracings in my note, make the appropriate referrals, and then if the child has hearing loss, share the tracking data to the state. So one thing that's important, particularly for our purposes, telehealth, is that video fidelity is critical. So number one, I think it's very important for building rapport with families to be able to see the physician on the other side who's going to be doing the appointment, especially when you've got a newborn baby and you're nervous about what's happening, you don't know what to expect, things like that. But then for me, it's important so that I can, at least to the best of my ability, monitor the placement of all the equipment that's on the baby. But then also, particularly for hearing screening, this measurement that we do, any sort of movement, so the baby kind of squirming or crying or things like that can corrupt my tracings. And so it's really critical that I can see well and see pretty quickly what's happening. So we use WebEx, and we use it through the University of South Dakota. It's HIPAA compliant, again, allows for a video call and simultaneously allows me to remote control the equipment in the computer at the spoke site. So at present, we have 3 different teleaudiology sites. One is Aberdeen, which is in the upper right, Pier at Avera Hospital System, which is in the center, and then Winter Regional Hospital, which is the bottom center. We used to have one in Hot Springs, but there was a recent change in administration and they closed the program there. But the good news is that we now have 2 pediatric audiologists on that side of the state. So we do have a place where children and their families can go. But strategically, again, we've placed these in areas where there's a greater loss to follow-up. So red is actually good here. Red means that there's a less than 10% like loss to follow-up rate. The highest ones are the blue areas. So what we've tried to do is strategically place them in regions where we can have the most impact. So some of the things that have gone well so far, at least as I have taken over the program, is that it has, I believe the teleaudiology program has helped get newborn screening added to, or hearing screening added to the newborn screening panel. We were one of the last maybe 3 states to get this added to our state protocol, and it took a while, but I'm glad we finally got there. We have great buy-in and referrals from the pediatricians at our sites. One thing that I need to do is actually now take a look at these numbers in the areas that we've established these sites to make sure that these follow-up rates are including or increasing. But I have a pretty full schedule. So once I established a specific date, you know, a date and time, I've pretty much seen patients every Tuesday, which is great. And then, you know, I work at the University of South Dakota training audiology grad students. And so it's been great to have audiology grad students there to see not only how, you know, the procedure of an auditory brainstem response works, but then also to see how telehealth works. Certainly there are areas or room for improvement. So one is most of the referrals I get are from the pediatricians and the physicians that are at the sites that we are at. So one of the things that I try to do every year as best I can is go to these different sites as well as the different hospitals in that region and say, hey, FYI, we're here. But I'd like to get more referrals from neighboring hospitals. Another one is that the Joint Commission on Infant Hearing has a diagnostic follow-up schedule for kids that pass their newborn hearing screenings but have risk factors. So say they've had a NICU stay, had certain viruses when they were born, but they still pass their newborn hearing screening. We like to get a diagnostic evaluation to check for later onset hearing loss between 6, 9, 12 months after they're born. And that's something that I think would be great if we could, as a state, do a better job of tracking our diagnostic evaluations after somebody has passed a newborn hearing screening, but have risk factors. Another one is intervention after diagnosis. We made huge leaps in this about 2 years ago, where we changed the kind of the state tracking form for tracking kids with hearing loss. In that, we included a form or 2 forms, one that allows us to share data with birth to 3, and then another one that allows us to share data with South Dakota Services for the Deaf. And in this way, we were able to at least get data to the data that we've gathered like directly to these different intervention services. But it's still pretty difficult to track intervention after diagnosis. One of those being the state tracking system. We are getting a new tracking system, and our state is working diligently on making that, on streamlining that. We are in the process now. Another one, again, for our state is that we have quite a bit of travel limitations. So there are a lot of people in our state that need transportation assistance, which can lead to no-show rates. Fortunately, we've had a pretty good no-show rate, as in very few no-shows. But getting people still, even at the sites that we have, sometimes people are traveling an hour or 2 hours just to get there. And then finally, as I kind of mentioned earlier, our sites provide this service to us for free. So they give us their time and they give us their space for free. But eventually we would like to be able to bill insurance so that they can get reimbursed for their time. My clinic can get reimbursed for their time. But another thing that fortunately we don't have to deal with, but was a big issue earlier, is that all of these services right now are provided through this federally funded grant. And earlier this year, it was unclear whether or not our funding would be cut. But fortunately, we were able to get our full grant amount recently. So we are able to continue this program. But that's one of the reasons that we're trying to pursue billing and reimbursement, is to make sure that if we do get federal funding cuts in the future, we can still sustain this program without that. So our future directions are expanding our teleaudiology sites. There's one more site that we'd like to add in South Dakota in particular. And then once we've expanded those sites, I think the next thing would be expanding our services. So at present, we only offer the diagnostic part at these different teleaudiology sites, but it would be great if, okay, somebody is diagnosed with hearing loss, say they want to pursue hearing aids or cochlear implant, that we would be able to provide them that follow-up there. So we'd be able to get those kids ear molds and hearing aids, or figure out how to get them cochlear implantation right at that site. Then again, as I mentioned earlier, providing education to neighboring systems, pediatricians, hospital systems, and then final future direction is getting contracts so that we can submit for reimbursement. So, and then finally, analyzing our current data to determine the impact of our teleaudiology services. And I think that's all I have.
Coral, thank you so very much. I do not see any questions currently in our Q&A, but please feel free to jump in if you would, like I said before, if you would prefer asking your question out loud. I am happy to unmute you. So that is an easy, just single click. So know that we can do that quickly. If you are interested in doing that, just raise your hand. You'll see the raise hand icon in your toolbar there, and we can ask those questions right away. Okay, just got a note. Oh, okay. Any questions from anyone? We'll wait just a minute or two.
Sure. One of the things that I have to say again, thank you for having me. And GP Track has been incredible as I, try to make sure that I'm following all the right steps, making sure that legally I'm doing the right things, and billing and reimbursement, just providing me guidance. It's been it's super rewarding to have that, to be able to provide these services, but there are certainly a lot of hurdles that we've had to jump through to make sure we do it right.
Yeah, understood. And we do have a question coming in, and I appreciate that that I guess confidence for us. But looks like Sean is asking, does CMS allow audiologists to bill without physician oversight?
Yes, yes, they do. These are also areas where I'm like a little, not as knowledgeable, but I do know that I can bill for those services. And I don't I don't think I necessarily need a referral from a physician. If we do sedated ABRs, however, so the child goes into the OR and we sedate them so that I can do it, we do need physician oversight there, certainly.
Just out of curiosity, is the licensure an issue? I'm assuming for you folks as well, just like everybody else. So you have to be licensed in the state where the patient is?
Yes. Okay. So I hold licenses in almost every state in the Midwest. So or North Dakota, South Dakota, Minnesota, Iowa, Nebraska. Um, right now, again, these services are really only offered in South Dakota. But I will say every once in a while we've had people from, say, North Dakota travel to one of those sites. And right now, the only reason and way that it works is because we provide those services for free, or the EHDI program is covering the costs of it. So one of the issues with starting to try to seek reimbursement and billing, and one of the reasons why we've tried to keep it kind of, for lack of a better term, kind of under wraps, is there are a lot of the families we serve don't have insurance, or the child isn't on Medicaid yet. And so we still want to be able to provide those services as quickly as possible to these kids without insurance being the reason that they can't be seen.
Yeah, great point. Great thought.
But fortunately, a lot of the systems that we've worked with have ways around that, within their own hospital systems, but it's just been convenient so far.
Yeah, so I'm thinking, I mean, North Dakota, I would assume that, you may have patients coming in from Nebraska as well, and
Yep.
So, okay.
And if we can, we'd like to, if we can, we like to see these patients in person. Fortunately, the telehealth program has worked very well. But it's also nice to see them in person so that we have a little bit more control over what's happening. But one other thing I forgot to mention is that we usually schedule these appointments for about 2 hours so that we can leave time and room for the baby to get settled. Sometimes it can take up to an hour for them to sleep, but then fortunately, once we get them asleep, it takes about 15 minutes. Can take about 15 minutes to do the test, depending on the results. But yeah.
Wonderful. Wonderful. Any other questions from our audience?
Yeah, one of the challenges that we've, I guess, encountered too is that we are not associated with a given hospital system. So you could see maybe on one of those earlier slides is that, we have to figure out how each hospital works and how they like their referrals and things to work. So it's been, again, great to reach a bunch of people, but it can sometimes be challenging to not have the same system to be working with.
Right. So I'm assuming that all this information gets entered somehow into each patient's EMR and
Right.
through access through the patient portal and all that.
Yep.
You're
So
working with
essentially,
two
yeah,
different.
I'll write mine. Oh,
Yeah.
go ahead.
Yeah, I would say you're working with a variety of different EMRs as a part of that challenge, I would guess.
Right. Right. Yep. So I'll write my report and then send it to the medical records team at whatever hospital I'm working with, and then they'll integrate it into the records.
Okay.
Yep.
Very good. All right. Well, if there aren't any other questions, we can give people a couple minutes back in their day. But thank you so very much for sharing this information today. I
Yeah.
know that if you're on the webinar with us today and you have any questions for Coral, I know she's open to answering those
Oh,
questions
yeah.
outside. So, but know that we will have this recording available, and we will send it out to everybody who is registered for the webinar today, and as well as the slides. So they will be coming your way, and probably in about a week or so. So maybe sooner. With that, thank you, Coral, and we look forward to having you all join us again in August. I believe it's August. I don't remember the date. I think it's the 20th, I think. And that will be a focus on behavioral health services in pediatrics. So watch for that information. If you are not on our newsletter, please let me know, and we can get you there, because that is where a lot of that information comes to you from. So, Carl, thank you again. And
Thanks for having me. Thank you, everybody, for joining.
yes.